Yes.
Medical Park.
Thanks.
And we'll get back to you shortly.
Thank you.
Alexander. So can we move to Medical Park, please?
On va prendre le suivant. Il a déjà un petit J.
Hello, Şevket. Şevket, can you hear us?
Tiens, vas-y.
Good afternoon, guys. Şevket. Do they hear us? Apparently not.
Let me introduce our team first.
Good.
We are here in Florida Medical Park. We have an RCA CTO. And we are working here with Fatih and Erdi. My co-pilot is Cüneyt, as always. So we are trying to prepare and show you our RCA CTO case. And let us first introduce you the case. Fatih will give some information about the clinical history of the patient. Then we will show you the double injection. And then we will have your, of course, advice how we're going to proceed. So let us first introduce the patient. Fatih, can you please introduce the patient, the clinical history of the patient?
Okay. Hi everyone. I am Dr. Fatih Güngören from Medical Park Florida Hospital. I will present the case. First operator, you know, Şevket Görgülü, and second operator is Cüneyt Kocaş. Our patient is a 55 years old male patient. He has hypertension, hyperlipidemia, and history of LAD stent implantation before 1 month. He is ex-smoker. He presented with unstable angina, and his ECG is no ischemic findings. We see. Echocardiographic examination show us ejection fraction of patient 55%. Laboratory findings is no significant, and creatinine level is 0.8. Right coronary angiography show us after the right ventricular branch there is a CTO segment, and it looks there is a microchannel after the right branch. And left coronary angiography show us there is some collaterals from epicardial collaterals from circ, and there is some septal collateral we see here. And after that we can return the cath lab and for procedures. Thank you very much.
Çabuk sunuyor ya.
Allah, evet.
So Şevket, we're ready to see the setup shots for today.
Okay, so we are trying to engage within LA1 here. So we have somehow made the setup shots. And this is what, Cüneyt? This is this one here. And where is my micro? Where is my balloon? Give me the balloon, please. So we will advance the micro catheter now. This is an RCA CTO, as I said. We have, as we previously have seen the patient, we were concerned that we don't have any retrograde collaterals, and he was anxious. But after, you know, you have to do the setup shots first. Without doing a double injection, you cannot decide how to proceed. And this seems to be going to be an easy one here. We didn't expect that, but after the double injection, it's going to be not so difficult other than the engagement here. So, and we will show you last in 1 or 2 seconds. Let me first make a ankle balloon here. Okay, so let's show them the setup shots. Our setup is we have a distal radial on the left, and the distal radial left extra backup EBU 7 French in the left main system, and we are trying from the right AL1 to engage the right coronary artery from right radial. So we have a right radial and left distal radial setup. So we have a choice extra support wire in the left main system to stabilize our guiding catheter. So we are very stable there. But on the right side, we have some difficulty in engaging the side branch and the the coronary itself. Maybe we are going to a normal right coronary Judkins catheter, but we will first show you the setup shots. Please, we have in biplane angio here. We have Philips biplane. We have done one shot, and we will show you the right coronary artery at the same time from left cranial and from the right cranial object views. So show them the...
Show the images.
Yeah, images. Görüntüleri gösteriyorum gençler. Çektik ya. So we have an epicardial collateral, and this epicardial collateral comes from the CX, and it's going right into the PL. And we have a clear channel there. I think this is a JCTO 1 CTO, but I don't think it's going to be so difficult. Maybe it can also be a functional CTO. We are not sure whether this is a real or not, and the patient's history, we don't have any information, real information, when the symptoms actually began. So we doubt this is a CTO. And now our actual approach is we want to go with the Mambaflex there, and then we will use a micro-channel CTO wire. And this is going to be a fighter. But while we are listening to your advice, we would like to engage the right coronary artery again. Please go on.
So, Şevket, Yüksel speaking now. Do you think set the wire for anchoring the RV branch with extra support wire?
This is the thing we were trying to do, but when we got into the side branch, then we have to change the balloon there, and while we're changing that one, it's also going into the right coronary artery, and we have also difficulty in going in this path. Now I will change again and will trap. Trap balon nerede? Burada mı? Şeyde mi?
Evet, trap balon şey.
Bunu alıyorum o zaman. Trap balonu mu o gerçekten?
Trap balonu, evet.
So we will trap the microcatheter, and we will afterwards do an anchor. But first, we would like to introduce the microcatheter to the lesion, because it was also not easy to go down with this wire.
So while Şevket deals with the nuisances of getting a stable guide position, anyone who would opt for another scenario besides tapered polymer jacket?
Give the micro.
I think the...
Ahmed, is it you?
Yes, it's me, Şevket. How are you?
Yeah.
Sorry, we didn't get
Hi. So I couldn't get your question. Can you repeat it, please?
No, I'm actually asking the panel if anyone would have another suggestion besides a tapered polymer jacketed wire.
I think the advantage of the CT before doing the CTO
that's great.
case comes in such a case where you are sufficient that it is not CTO and there is a channel. And the CT can show this and clarify it very well. So in part of the planning to do CT, we make sure that it's not CTO or CTO. So take point.
Did you do CT for such a patient?
Let's challenge the eye. So what exactly are you hoping to find from a CT? The presence of a microchannel?
Now, the channel, that is not CTO, that after the branch, the RV branch, there is some filling there. So by CT, you will see that this is filling, it is not a CTO. And so you can appreciate why CT, is it really there's an occlusion, a CTO, or there's no occlusion?
It could be a functional CTO.
I give it to you. How exactly is that going
Bu nerede şey?
Öbür dalda abi. Öbür
the
dalda.
plan now in terms of
Bastırıyorum biraz.
Bastır biraz. Küçük testlerde.
In this case,
So the problem is I can easily going to in right Judkins, but the patient had the vagatonia, and we had to give him 2 milligram atropine, so I don't want to have him pain. That's the reason why I am still trying to do something with this guiding catheter. If I would go with in right Judkins, I would easily be engaged and do my job. But here I will still use this one with slow movements without giving the patient pain. That's the reason why I struggle.
I think
so, but now the problem is the wire is now in the guiding catheter, in the microcatheter, and we are going into the branch.
Why don't you go I think it's better to change the catheter from from the beginning of the case.
It's nice that to anchor stable catheter.
Yeah, but the problem is now we have the wire and the micro catheter, and when we change it, then it goes down. Then we trap it out, and then it's vice versa. So
When he's back on the micro catheter, it's now
Sen second wire.
versene şeyi ver
Sen
şimdi.
second
Samurayla git. Samurayla git. Samurayla oraya girelim.
So now if he's
Dursun
going
orada,
to the
dursun
side
öbür
branch,
taraftan
he'll
bir
have
tel
to
daha
trap the
gönder.
micro catheter out. So we have a question.
Just a quick
İçeriden
question.
dışarıdan git, dışarıdan, şuradan.
You have 7 French over there.
Bir açısını
Seven French, yeah.
introduce
Yeah, and you
ver.
have got a muscle spasm or spasms of the vessels is your fear. So you can
Yeah,
probably,
the patient has pain in arm, so
Yeah,
that's the
so-
problem. So I don't want to retrieve the
So you can-
Judkins catheter and give him more pain.
no problem.
So-
But if you go in with you will cause him pain when you bring it out. But if you take it a 6 French, an XBRCA, that may hold better over here. A 6
Yeah, I
French.
can do that, but as you know, as you have said already, this is not a CTO really, you know. So I would like to do this.
Well, we have had some CTOs which did not look like CTOs but became CTOs.
So Şevket, we'll just give you some time to work. Any other suggestions from the panel in terms of how to
Mikro
tackle
kateterden mi
the
gitti bu?
CTO?
Aynen, mikro katetere götüreceğiz abi.
Oradan mı gitti?
Vay,
Emin misin?
Evet, evet,
Süpersin.
mikrodan götür.
Okay, now we have some leverage here.
Ben tuttum sen
Yeah.
gönder.
Yok yok, sen bana bırak.
But you will have this problem all the case. So fix it with anchoring balloon.
I will do that, but first let me go down with this one here. Now I can have now I have blocked this way. I can go now easily to the anchor balloon. Okay, give me the other one now. That was what we wanted to do.
Then it's difficult
give
to
us
go
the
at
samurai
that
or access support wire.
Samurai.
It's
Extra
good that
support
you're
line.
keeping everyone
Choice is-
awake in the last session, Şevket, so I'm seeing very alive faces around me. Oh, that's
No,
good.
I'm happy
now-
to
now you're
be
getting
staying
the
with you, so
anchor wire.
you can have some talk. But
Anchor balloon.
sorry, this is not an interesting case. So this is an
seems
interesting
Omar is
case. Yeah,
pretty much
give me the right
interested. I can't
Judkins.
get him
I
off
don't
the-
want
off
to
the
struggle
mic.
anymore.
You made it interesting. No problem.
Yeah, it's going to be
I
interesting.
assure
Yeah.
you there are a number of
Give
interesting
me right
faces
Judkins.
sitting right in front of me.
Seven French right Judkins. I
Why
don't
do you
want to
have a
struggle anymore.
comment?
There
So
must
this is
be
going to be
interaction
annoying.
between the
Give
two
me
guides.
six
So
French
if
and seven
you
French.
Higher, seven
video
French.
back, then it will be easier to
exchange?
see the AL. So they are interacting. The AL cannot relax.
Yeah, that's
with
a
it.
good point.
The issue here that
So-
without a stable guiding cath, you cannot proceed for such
Can we
lesion.
skip that part with the
Yeah.
guide support?
Yeah.
Gönder.
Okay.
Check,
Şevket,
check,
if you don't mind, we'll let you do some progress in peace.
Yeah, of course. It's boring this part, I know.
And if
For
we
me
can
also.
see-
So hadi şimdi şey alalım.
Is
Sağa
Cal
geldik
done,
alalım.
guys?
Ver bana.
Does anyone know what's happening in Memorial? Is Cal done? Are they ready for us? Do they even want us to join them?
Or maybe you can go back to Alex.
Okay, we can go to Alexander and see what's happening.
Hello, Alexander. We are back again.
Okay. Hi guys.
Hello,
We are
Şevket.
still struggling here.
Yeah.
And I have a micro channel wire here, fighter, and I am trying to find a resistant point so I can go down with that wire, but never underestimate a CTO. So you see how I am struggling, and I have
Is it better cannulation
difficulty in knowing the proximal cap. Maybe we have done further shots. Maybe you want to see the further shots, but this is a kind of angulation after the right ventricular branch. So we hope that this fighter will smell that channel and go down, but so far we have no success. We will try, of course, but now we have stabilized our guiding catheter with a anchor balloon in the right ventricular branch, and at least we have some kind of stable environment here. But still we are trying to find the channel. This is a fighter and a Mamba flex, 150.
So the guiding cath is now in better position and the patient is more stable. At least you can work at peace.
Şu an geçti gibi
Karşıdan
sanki.
bir bakalım.
Bakalım.
I think
Fluorokustor yap.
the system is
Fluorokustor.
not stable, and the system
Hadi.
endangers the procedure for further steps to be outside.
Yani.
Neredeyiz? Emin misin?
Yani fighter sonuçta
Çok
gönderelim bence.
çok iyi gözükmüyor
You
şeyde.
anchor your balloon at side branch. Anchoring, yeah, but it will change the anatomy of that part. I would anchor it at proximal vessel.
Yeah, we tried it. You have seen it already, so we couldn't manage it. So the first thing is we don't want to lose what we get already. So that was the reason why we anchored at the right ventricular branch. So this procedure is already going to be a nasty one. So we didn't want to lose any more time and tackle the CTO. Şey göremiyoruz ki, bir retrograd şey görmemiz lazım. Bakın görmemiz. Sol 30'da gelsene.
Normal
bir görelim.
sonuçtan tekrar bakalım, bu daha iyi.
So this is still the fighter wire, Şevket, right?
This is a fighter, yeah.
Sol 30, sol.
It seems not bad, but we don't have any backflow, and we have only, I think, a very weak epicardial collateral, and the collaterals are ipsilateral, so I want to have...
You go somewhere else.
Yeah, it's
Yeah.
the opposite.
It doesn't look like it's in the right direction now.
Nah, it's not. It's not. It's not.
Why don't you go to RAO,
RAO,
and to see?
Yeah, change the projection.
I think at this point in time, the LEO view is very deceiving, to say the least.
Nasıl? Gene orada başka bir dala gitti.
Yine araya gelelim, oradan
Okay,
gidelim.
we want the arrow, please. Bir daha mı görüntü alalım?
Hem görüntü alalım.
Alalım.
Belki daha iyi anlarız.
Okay. Yok, öbür taraftan alacağım. Hadi.
Very nice collateral. Do you see that?
Yeah, you want me to go retro, huh?
I don't
In this kind of channel,
We have which kind of channel? We have ambiguous cap here, more or less.
you mean this is an ambiguous cap? If you say so, I would be very happy. So at first, I would thought that this is going to be an easy one, and I am trying to struggle with this easy one. Okay, I go happily retro. Thank you, Ömer. Okay, we go retro, guys.
No, I didn't see
Go retro.
channel. I wasn't
We go
here.
retro. Give me another Mamba Flex 150 and give me Samurai RC, okay?
Let's take an array.
Okay, let us take the channels, okay? I would like to see. Okay,
Şevket,
thank you very much. That
Şevket.
helped a lot because I thought this is not a CTO and we have some kind of channel there, and I didn't want to make it more
It is very
complicated. But
CTO.
I like it. Thank you very much.
Cemil
much.
said that we have a rules for in CTO business, you know, and I think the number one rules should
Okay.
be never
Give me. This is good. Thank you.
CTO.
Mamba 150 versinler bana hadi. Mamba 150 and Samurai RC, please.
Can I have a humble suggestion? Now you have a perfect anchor in the RV branch. Just get your guide and get a good anti-grade shot. I mean, there's nothing to pay. There's no price to pay for an anti-grade shot now. In an REO production, figure out
Ahmed,
where the
when we
proximate
go
cap
with
is.
an anti-grade shot, we cannot see anything. And I have a micro.
So the panel of grandmasters.
I have
pushing you.
a anchor balloon there, and if I retrieve the anchor balloon, I will easily lose this wire. İki önceye git. I will see broken the right corner, the guiding catheter, and it was possible with deep engagement. I will show you how I engaged. So therefore, I don't want to lose my position. Bir önceki, Floro, bir önceki. Oturuş şeklini göstereceksin. Bir önceki. Yeah, you will see how we engage now. You see this is a broken one, and I didn't change this one. And you see now I am going deep and deep.
Onu safe olarak.
Wait. You see I have done this. So at this point I was able to engage in the right ventricular branch. So it is not easy here. It seems a piece of cake, but it is not. No.
You will pay for that. You will.
I know, but I don't want to lose time.
Okay.
Bu ne verdiğiniz ne?
Bu Corsair Pro.
Tamam.
So what's your plan now?
So persistence is good. I'm not sure that this will not come to bite you at some time. during the procedure, just wasting some time.
So give me,
If you are.
give me.
But anyway,
Samurai
Şevket,
RC.
so what's having gone retrograde? What's going to be your
Corsair Pro and IFE Samurai RC, I will just go into the septal. The one we see is visible there. Let us show the angio, please.
Tamam bir
Bu
tane
ne?
RC versin başka
Bu
RC.
ne?
RC ama düz samuray
Bu ne?
RC istiyoruz. Run
Okay.
Dönmek için. Ortadakinden döneceğiz abi.
Ver bakalım.
Samuray RC.
Sağ cranial'a gelir misiniz gençler?
Sağ cranial,
Right cranial please. Bir de şeyi atsana. Görüntüyü at.
Burada bir görüntüsü var bunun.
Biraz geri alıyor. So IFN safety while already there. Bu mu?
Bir sonraki. Tam ortada.
Which septal you are going to select?
Öyle yapacağım.
RC'de alıyorum.
Maybe we can try it.
Yok. Bu şeye çıkıyor. Yukarıdaki saçma sapan dala çıkıyor. Görüyor musun? Bu ne? Diagonal mi bu?
Değil mi?
This is a workhorse probably, but trying to engage yourself.
Bir de FC alalım istersen.
Bana Fielder FC verin gençler. O saçmalığa bak ya. Fielder FC, please.
Change the angle. Change to
I will do that. Yeah, I will do that. But at the meantime, I will.
Angle of the curve, you know, because wire goes that way.
Ver, ver, ver, ver, ver,
No
ver.
more.
Ver, hadi.
Change it. Goes somewhere else.
Ver.
FC.
Ver, elindekini verir misin? Run-through'yu ver. Hayat, run-through'yu ver.
We'll leave your work in peace, and we'll go check what Alexander is doing because he's battling with a very diseased
Okay,
as well.
no problem.
And come back to you. And
We are good here.
we actually have a lot of time still waiting in that session, and we have.
2 secondes, je recule mon truc.
So perhaps go with the first.
So perhaps we can go with the first presentation.
Kızdım. Nasıl yok şey yani?
And then we can go back to Şevket.
İlla kızıyorum ama sonra da böyle yapıyorum.
So the first talk.
Yok, ellerinde malzeme yok. Sonra
Dr.
onun bunun
Şevket
malzemesini kullandın diye.
Challenges of CTO PCI in the developing world, a case example. Is Dr. Şevket around? Yeah.
So in between the cases we will go back to
Pozdan mı
the
geçelim ya? Ben onu
Pas 48, tu vois, regarde.